We'll all just have to remember it. We'll add it on.
Yeah,
And,
we'll add it to the website. Thank you for that reminder, Tim. I appreciate it.
Well, we can hear, though, about Richard Snepar, who's an infectious disease specialist who will be speaking with you tonight. He has treated COVID-19 patients since the onset of the pandemic. His areas of emphasis include infectious diseases, infection control, travel medicine, consultation, and management, all of which obviously have been critical during this period over the last year. He's an attending physician at the RWJ University Hospital, at St. Peter's Hospital Medical Center, as well as at Central State Medical Center. He received his MD from the Joan and Stanford Weill Medical College at Cornell University, and it's a pleasure to have Richard here with us tonight. I also want to introduce Dr. Ashgan Elshinawy, who's also board certified in internal medicine, as well as pulmonary and sleep medicine. She received her DO degree from UMDNJ at now Rowan School of Medicine, and her pulmonary sleep fellowship training was at Memorial Sloan Kettering and NYU Medical Center in New York City. She also treats COVID patients at Penn Medicine Princeton Health and is medical director for the Center of Breathing Disorders at St. Peter's Hospital. She's engaged in previous educational webinars on COVID pandemic and addressed concerns and skepticism that surrounds vaccination in many populations, but especially in both healthcare workers as well as people of color in New Jersey. So it's a pleasure to have you, Ashgan, as well as Richard.
Thank you.
I'm going to briefly start off by showing a couple of slides to let everybody know where we're at in this pandemic. So bear with me while I remember how to do this and play from the start. And I just want everybody to remind all ourselves where we are. This is a slide from the New York Times. They do a nice job of maintaining data. And you'll see just in the past, I did this slide midweek last week, but still today, in the past week, New York and New Jersey, Rhode Island, we're still among the states that have the highest case rates per 100,000 residents. So while it may feel like things are getting easier here in New Jersey, we're still number 3. You might also note that deaths from coronavirus cases in the United States, and that, again, this is about a week ago, New Jersey is the state with the highest death rate in the United States. We've heard a lot over the past couple of weeks and months about California and about some other states, but New York, New Jersey, and Massachusetts are still the states that have had the greatest mortality impact. So we both have continue to have a high case rate, and over the past year have had a very high mortality rate. Drilling down into Mercer, over the past, we've had 164 cases overall, and the daily average at any given time is 99 and 27 per 100,000. Not nearly as high as some of the other places, but if you look at it, about 1 in 14 people who live in our county have been infected, and 1 in 430 have died. So you can see those slides there specifically about Mercer, and they let you know that, again, we're not out of the woods, not out of the woods in New Jersey, we're not out of the woods in Mercer County. And unfortunately, this is a slide that I've made up. This shows you doses delivered of vaccine per 100,000 population by county in New Jersey. And unfortunately, at least up until this time, Mercer County is not among the leaders in doses given. There are various things we could talk about. Perhaps we'll talk about these tonight, but that is to set the stage as to where we are. And then finally, this is a study done by our friends at a company called STAT, who looks at health data. And they did data to look and see which counties with the highest per capita income and the lowest per capita income in a given state to see what type of disparities there were in vaccination. And New Jersey was 3rd in the nation. This is not a great thing to be 4th in the nation, not a great thing to be leading on, showing the biggest gap in vaccination between the counties with the highest per capita income and the lowest per capita income. So that sets the stage in terms of data for where we're at. We're still having plenty of cases. We've had a lot of deaths. And I want to start by asking first Richard and then Ashgan. Richard, tell me what you're seeing. You're seeing patients. Tell me what you're seeing and what your sense is of where we are in the pandemic as of this Sunday night.
Well, yeah, it's interesting because I just was in the hospital all weekend, and while we saw a onslaught of activity with increased admissions, increased illness due to COVID, really coming out of October into November, December, it looks like we are starting to slow down a bit. The case numbers, the population in the hospital of COVID patients has gone down. The numbers of patients hitting the emergency room are starting to slow down. We're getting less consults per day. And so it looks like we're taking a turn, in the right direction. There are still cases in the hospital. It does not look anything like this summer did when the hospitals that I go to were nearly empty. But they are going in the right direction.
And Ashgan, what are you seeing?
Good evening, everybody. Thank you again for having me as part of this panel. I really appreciate it. So I definitely see a similar trend as Richard does. At the beginning of the pandemic, it was rather ugly, for lack of a better word. Not only did we have a surge of patients that we just didn't know what to do with all over the hospital, but not only the number, but we just really didn't know how to treat them effectively. So that was an added just tragedy. So as the months progressed and over the summer, we had a little bit of a respite with the warmer weather. And then when the fall started, I noticed the uptick at Penn Medicine, Princeton Health. But just like Richard said, definitely we're seeing dwindling number of cases over the past, I would say, 2 months. What I'm noticing is, even though I'm seeing still a good amount of COVID patients in the hospital, I'm also seeing quick discharges, which we didn't see at the beginning of the pandemic. And I think that tells me that despite all the mutations and the variants and all the stuff that's going on, we're doing a better job and we have access to better medications, and we know a little more than we did at the beginning of the year. When I say beginning of the year, beginning of the pandemic, which is March of 2020. So we're seeing better results. People are getting better. People are dying less often, but there is still a lot of cases, and there's still enough deaths to really not ignore this.
Well, those are rays of hope, if I'm hearing the two of you correctly. And there's the big ray of hope, and that's what brings us together tonight are the two vaccines that have been approved in the United States, the Pfizer and the Moderna BioNTech, the Johnson & Johnson vaccine, which sounds like it's going to go to consideration for at the FDA this week, and other vaccines. And before we get in, we're already getting a lot of questions, particular questions about the vaccines, but perhaps Richard and Ashgan, you can set the stage for the people who are on the call so we're all on the same page. Can maybe you tell us about the two vaccines that are currently available and what your sense is of how they're working and how people are accepting them? Maybe start with Richard.
Yeah, let me give you, before we go into the current vaccines, let me just give you a little feel for vaccines themselves. I mean, prior to this mRNA vaccine, which is what we're going to, main one we're going to talk about, we had conventional vaccines, and they came in several types. One was a live vaccine, a live attenuated vaccine, and that was where you just weakened the live virus, and that was the typical vaccine would be measles, mumps, or rubella vaccines. And then the next group of vaccines is the the inactivated vaccines, and that's you inactivate a virus. It's not live, and that's classically the influenza vaccine, and that's the one, the ones we're familiar with. I mean, there is a live influenza vaccine, but not very popular. Then there's the subunit vaccines, which, for example, you take a piece of the wall of a bacteria, such as you do with the pneumococcal vaccine, and you administer that for an immune response. So those were the conventional type vaccines, and then but what we're dealing with now are is a different group of vaccines utilizing different technology. I don't know if Ashgan, you want to talk about that, or you want?
Yeah, well, that would be good. Sounds good.
Okay, so I think I want to just address one point, because I have a feeling everybody's going to be asking a lot of questions about vaccines. So I want to address a question that I got, especially at the beginning in December, January, when the vaccine was first approved. When I say vaccine, the messenger RNA type, which is Pfizer and Moderna, there was the huge concern that this was done at a warp speed mode and accelerated and done faster than any vaccine known to us. I mean, the second fastest vaccine that was made in our history, and Richard, if you correct me if I'm wrong, is I think the polio vaccine, and that did amazing things for in our lifetime. So what happened here is that there were no corners cut by science. It wasn't an accelerated thing by cutting shortcuts and taking shortcuts. I mean, it was done because there was adequate funds, there was enough sponsors, the federal government poured billions of dollars into the manufacturing and the research of these vaccines. And the reason why they did it, and it was necessary, is because we were in the middle of a pandemic, and we have not basically experienced a pandemic. Let's say 100 years ago was the last one, or the influenza pandemic. So in our lifetime, we have not experienced this before. So the messenger RNA technology has been already out and has already been studied for other diseases. It hasn't been rolled out yet, but they used that technology and they poured the money that was readily available. So this is the first time the pharmaceutical companies did not have to take the risk by pouring their own money and go step by step, which takes 5 to 7 years potentially, because they reduce their risk that way. But because we gave them the money up front, they were able to do it in a matter of months. So that's a main black and white, bread and butter way of explaining it. So it wasn't short-sighted. There was any shortcuts taken. It was done the way any trial would have been done. It just was done in such a way that it was in a condensed 7 or 8 months.
Now, so we've heard about what the various types of vaccines in the past are, and currently obviously being given. Ashgan, you put in good context as to why this particular way of funding vaccine development led to really this wonderful availability of these high quality vaccines at a year. Can you tell us, again, to set the stage for everybody, how effective are these two vaccines and what kind of side effects are people seeing with them?
Me or Richard? Richard?
Either one, jump in.
Okay, I'll take it. Okay, so far what the trial data has shown from both Pfizer and Moderna is when they looked at the 40,000 people they studied each, so 20,000 with placebo and 20,000 got the vaccine, they noticed that there was about a 94 to 95% efficacy with both vaccines. And what efficacy means, because this really becomes a very important point as we talk about other vaccines and variants. Efficacy means you get the vaccine, and what is your chance of getting the infection, or what are the chance you're protected from getting the infection? Okay, so 95% of people who got the vaccine, whether Pfizer or Moderna, did not go on to get the infection when they followed them for months out. So that is pretty remarkable. I don't know of any other vaccine in recent history that has accomplished that, especially with this new technology. So it doesn't mean, and we talk about the variants, we'll do that later, but even if you do get infections, in the trial data, very few people, a handful of people got the infection after they got the vaccine. But the key there was they were mild to moderate at worst. So no hospitalizations, and not a single person died who got the vaccine, even if they got COVID infection. So that's a huge.
So these are two highly effective vaccines for the current variants that are out there. Richard, have you seen people who have had vaccine side effects? And if so, what kind of side effects have they had? And should side effects deter people from getting vaccinated?
Okay, well, the side effects are, vaccines have side effects. There's no question about that. The most common side effect is pain at the injection site. Now, you might say, well, naturally I'm going to get a shot and I'm going to get pain, but about 80% of patients who get they get the vaccine do get pain compared to at the injection site, compared to about 18% of people that get placebo. So, there is pain associated with it, and that's, part of the inflammatory response that's associated with the vaccine itself. It's nothing that's horrible. It goes away. And then there's the other side effects, which include the next most common side effect is redness at the site, and we do see redness in probably about 40% of patients. It'll lasts for generally with the Pfizer vaccine, the median time was about a day. With the Moderna vaccine, the side effects generally lasted for 2 days. Second, the fever in 25% of patients.
And have you been giving specific advice to your patients, either of you practicing physicians, about what they should do when they get vaccinated, whether they should plan to take a day off or plan to take any pre or post medication? Richard first, and then Ashgan second, because I know people have asked this question to me, and I know people have already asked this question online to us. What should people do in preparation for vaccination and then immediately after their vaccination?
Well, in terms of preparation for vaccination, you'd really want to go in medication free. Certainly, you don't want to take any anti-inflammatory agents prior to getting the vaccine. Post-vaccine, it's controversial, but by and large, one could take, if they're having discomfort, they could take Tylenol. If you had to, you could take a non-steroidal. It seems to me, just anecdotally, I don't see anything out on it yet, but it seems to me the younger the patient, or if patients had COVID, the bigger side effect. As we get older, there's a little bit of immunosenescence where you're going to get you see less of a response, less of a febrile response.
And Dr. Elshinawy, is that what you've been seeing with your patients who've been vaccinated?
Yes, I've been seeing a little more side effects after the second vaccine, more so than the first. So I think because it has that booster effect, your body just, it's this second time it's facing this foreign thing. And so it has more of an inflammatory response. And I'm definitely seeing it more with people under the age of 55. And that kind of reflects the data that was presented by the trials, that they noticed more of the side effects in younger people. And so, for those of us who are above 55, one silver lining, we don't get too much side effects from this vaccine, but it doesn't mean it's working any less. There's no evidence of that at all.
Well, that's actually one of the questions maybe you can speak to, and then Richard will speak to. We hear that it's got a very high number of effectiveness once you've completed both shots. There's a lot of information that's kind of coming out now. How soon after the second shot? People have asked me, can I go back to my quote unquote normal life? Even I've had my own aunt ask me, hey, it's been 10 days, 2 weeks after my first shot. Can I go to my poker game? How do you deal with the patients who negotiate with you, or maybe patients who just ask you very honestly, when is this going to make a difference in my life?
That's a very, very common question because after all, we've been waiting a long time for these vaccines so that we can resume normalcy. And a year into this pandemic, I actually don't even remember what that means anymore. But it's two-part answer. First, know that scientifically, you're supposedly fully immune 2 weeks after your second vaccine. So I play this negotiation thing with most of my patients who ask me that question. And I'll be very honest with you, my answer to each person is different. I personalize it for each person because there's different environments they're going to be part of. They're going to be around different people. The number of people they're around. Are they around elderly or immunocompromised people? Are they around people who have not yet been vaccinated or 2 weeks after their second vaccine? So I still tell them, pretend you did not get the vaccine, meaning if you want to go visit your relative who you feel is safe to visit, please still wear a mask while you're in their home. Stay socially distant. At least you'll be in their home, and you'll have that extra layer of protection now, the vaccine, but the mask is your second layer.
And Richard, you see patients, but you also work around other doctors and nurses. What insight can you give us into how both your patients and perhaps your colleagues in the hospital, how they're dealing with this issue of what can I do now that I'm vaccinated? Or, perhaps the physicians and nurses are saying, is there a sense of relief among the physicians and nurses that perhaps they're not quite as much on the firing line at the moment?
Oh, yeah. And well, as Ashgan was saying, this is the $1 million question. So there's definitely a sense of relief, which I felt as soon as I got the vaccination, the first vaccination, and you feel like you have a shield. And you feel, people were saying, actually, it was yesterday or today, that going into the patient's room, you just don't have that that concern that you're going to get the disease, which we've all had, from the beginning of this pandemic, which, takes a lot of anxiety, off the table. And, based on the studies with the vaccine, it's, you can feel that way. Or
Have any of these studies talked about how long that, I'll put it this way, how long will that feeling last based on how long the protection will last? This is one of the questions that's being asked in the chat room. Okay, I've been vaccinated. How long will my immunity last? Richard, and then Ashgan.
So that's right now they're saying the immunity, they're giving it 90 days. So and that's also if you look at the Moderna study, or there's Moderna data that your immune response will last at least that far out. That's not to say that it's not going to last longer, but that's pretty much the length of time that they're posting.
Well, I'll interject one thing here. My understanding, and maybe Ashgan, you can correct me if I'm wrong, that both the Moderna and the Pfizer trial, and then in the future, the J&J trial, they're going to keep following the vaccinated patients to see just how long these vaccines the protection does last. Do I have that right?
Yes, that is correct. And to add to what actually you both were saying, not only are they following these patients out way past the first few months, and so far we're seeing 5 months of immunity, but it's not because that's all we're seeing, it's because that's the only data we have. We still have to follow that. These people literally just finished their trials 5 months ago. So, and I could tell you the added vignette of the Pfizer vaccine, they have started a trial on younger people, ages 12 to 17, that they started in October. And just again, this helps answer your question further. What they're doing there is not just following these kids to see if they get infected, but they're also actually checking their antibody titer. So they're actually doing blood tests on these kids a couple of weeks out and then 3 months out. So the latest data show that 3 months out, because they started in October, and in January, they saw that they still have pretty good elevated titers. And I'm sure they'll follow them out like 6 months later. These are the kids that are in the trial data. So it's really, really good news coming out of the younger population as well. But yes, they will continue to follow, and we'll have more answers for you in the next 6 months.
So we're closing in. We have a few more minutes left to do the three of our dialogue, and then we're going to turn things over to Tim Quinn, who's going to ask us questions from the audience. But one of the questions I want to get to is, I think one of the questions that's on everybody's tongue. Okay, I haven't been able to get vaccinated yet, and I took a couple of these calls myself today. I haven't been able to get this vulnerable relative of mine vaccinated. What can I do to continue to protect them? And how long realistically am I going to have to wait? I can actually, if you want to, if you, at some point I can speak to that last one, but what do you tell your patients? Because I'm sure you're being confronted with these same questions. Gee, I've got a relative, a wife, a friend, they're old, they can't get the vaccine. What should they do until the vaccines come online? Richard first, and then Ashgan.
Well, what I've been telling the patients is that they basically need to go to the New Jersey government sites and enroll and try and get a spot. It's been difficult for them. There have been places you can enroll as well, with some of the hospital groups, but maybe Ashgan can speak to some of these other sites.
Yeah, Ashgan, what have you been saying?
Yeah, almost everyone I know, the first question they ask me is like, where can I get a vaccine? Are you giving it in your office? Can we get the vaccine in your office or pharmacies? It's kind of sad because we rushed getting these vaccines made and approved, and we can't get them in the arms of people. So I've been providing the New Jersey site, but I've also been trying to, as centers pop up with their sites, I've been just accumulating a list of them. And I actually made a couple of slides that I'll share with everyone towards the end so that you can copy them or click on them and save them on your computer. So they belong to different sites like Robert Wood Johnson, Penn Medicine, Rowan University has a huge mega rollout, and they're accepting people from different counties. You don't have to be just from there, South Jersey. So I will have those listed. And I say, if you meet the criteria of the category of the day, go ahead and register. And if you get one ahead of time, then go ahead and cancel your registration for the other sites. Because I also tell people you can't mix and match. If you start with Moderna, you got to stick with Moderna. If you start with Pfizer, you got to stick with Pfizer. Can't.
So I want to get to a couple more questions before we turn it over to Tim, and before you show your resources slide. But one question is, it seems like, and maybe it's just me, but I got variants on the brain at the moment. This variant, that variant, they keep talking about all these variants. What do the variants mean? And do we know what the variants mean about vaccination at this point? Ashgan and then Richard.
Okay. We know some things. Okay. The Pfizer and Moderna, it just so happens that they were completed and approved and administered way before these variants came before us. So the reason we don't have really great data is because of that, because they weren't really tested on these variants. However, they have started doing what's called in vitro studies, which means they're not testing people, they're testing this in a test tube in a lab. They're basically getting antibodies from a person who's been immune to the virus, and then they're mixing it with a synthetically made virus and mixing it together and see what happens to the virus. That data hasn't been that encouraging. It shows that the efficacy goes down by 2/3 for the variants. And we're talking about the UK, the South African variant. However, I want to caution people that even 2/3, less than 95%, is still pretty darn good. And remember, we're not just trying to prevent infection, we're trying to prevent severe disease from the infection, and we're trying to prevent death from infection. And so far, across the board, that data has been very encouraging.
Well, let me react to that just briefly, to put in a plug and say that what I hear when I hear you describe that data, that means that given that these variants are, we know they're circulating in the population, vaccinated people should still be taking precautions. And I suspect you both agree with that, but I'd love to hear your form of amen on that one. Maybe Richard, what do you tell your patients when they come to you and say, hey, this is great, I've gotten my vaccines, now I'm free to party? How do you communicate to them that they're still going to need to be distancing and washing their hands and wearing their masks? They may be very tired of hearing that message.
Well, you know, the vaccines have demonstrated that they will protect patient or people against disease, and they'll definitely protect them against severe disease and death. But what it's not talking about, and what we'd like to know, and we don't really know for sure yet, is it doesn't really reduce transmissibility, and to what degree it reduces transmissibility. So you still need to carry on as one did. Until we're certain that we're dropping the transmissibility to nil, which, you know, may be expectable, but it's just not. It just has not been fully demonstrated yet. You need to mask well, you need to social distance, you need to, you know, keep this area clear or protected, and
So what I hear you saying is, if you've been lucky enough to get vaccinated, you're now protecting other people. Is
You
that
should.
you still are wearing things to protect other people? And maybe I'll turn it over to Ashgan and you can answer, and then it's time for you to share your get ready to share your resources slides, and then we'll turn things over to Tim after you share your resource slides.
Okay, I just want to add one thing to talk about variants and protecting
Definitely.
people. So yes, it's extremely important to continue wearing your mask and socially distancing after you get your vaccine. One, you're still not 100% immune. Remember, these are 95, which is remarkable, but it's not 100%. Second, these variants can still infect you, because we don't know how effective the vaccines are against the variants, really. And three, we don't know if you get some droplets in your nose and mouth after you've been vaccinated, you may not get sick, but you still talking and laughing and with anyone else, and they can certainly get sick from you. We don't have that data, and until we do, we should assume that we can still get someone sick. And I want to make a point about herd immunity. The way we're going to achieve herd immunity, which means enough of the population is immune so that not only the pandemic ends and less people are getting sick, seriously sick, is we have to vaccinate at least 70 to 80% of our population, meaning the country and hopefully the world, because we are traveling, right? Or we wish to travel one day soon. So we have to encourage that, and that's why we're doing webinars like this nonstop, to really inform you guys so that you can make a better informed decision for your health and for your family's health. But when you make a decision, it affects so many other people. Please remember that.
Well, why don't you turn to those resources and see if you can pull those up to share them on the screen for us.
Okay, here's one, and I'm wondering if Tim may if there's a way to get these onto the chat at some point.
Dr. Elshinawy will be emailing your slides and also other resources to our members after this program.
Perfect, even better. So this is just a preview then, you don't have to worry. And then I have the numbers as well as the actual sites, state resources. And then of course, general, I've included this because a lot of people have been asking me also, what's in these vaccines? What are the ingredients because of allergy risks and stuff? So you definitely can go here and find that information out too. Okay. So these will be shared with you after the webinar.
Outstanding. And I think that would be our call to turn things over to Tim, who's been actively monitoring the chat. I know I got a chance to respond to a couple of comments, but not really most of them. Tim, what are you seeing in the comments?
So early on, there was a question. We're noticing that the cases are dwindling. What would you attribute that to? Why cases are dwindling now?
I think if I may just make a theory here, I think since we saw a really big uptick in December and January, and I think that's probably the result of holiday celebrations, get-togethers, travel to families and abroad, and so we expected that uptick, and we did get it. And then after January and New Year's was done and over with and people were back in their homes. So I think part of it is the behavior modifications that followed after the holidays. So people were back in their home, socially distancing again. They realized, oh my God, look how high these numbers are. We're reaching 500,000 cases a day. This is crazy. So people were more careful. And plus, of course, the vaccines were rolled out as of December 11th. So perfect timing with the holidays. So I think those are the two main reasons why we're seeing a decline in cases.
And Tim, the only kind of yellow sign I would give as opposed to a green light is that, and this has been a comment that's been made, and I go back to the first slide I showed, we still have a very high rate. So in a sense, the patient's temperature has gone down from 105 to 101. So this is not a normal temperature. It just is, the patient's much better than he or she was, but they're still sick. So I think the 7-day rolling average was at 70,000. Back in April, when we thought all hell was breaking loose, the 7-day average in the United States was 30,000. So if you think April was bad, now the reason you think April was bad is that in New Jersey, we had an incredibly high rate in April, but the rest of the country did not. So I think we're not out of the woods, but things are better than they were.
Yes, and we're also we're far from a super spreader event. We got a nice distance from New Year's right now. We don't know what the Super Bowl is going to do, but we're getting a little bit away from that. But so we're away from a big event, and we're also, I think people are being a little bit more compliant with masking as well.
Thank you. We had a series of questions about Mercer County that I imagine that Dr. DiFerdinando will want to address. The first one had to do with the chart that you posted about the number of vaccines administered in the county. Does that include county residents or just people who were where the vaccine was actually administered in the county?
So it's first of all, I get that data from the New Jersey State Health Department. They list the number of vaccines given within the county. So I know some people in the chat and other people have said, well, I went to Rowan College, or I went to, one of my friends went to the fire station in Middlesex. Those are attributed to those counties. So what it's saying pretty bluntly is that more vaccines are being delivered in other counties. And what that really, so the upside is that some of our residents are being vaccinated elsewhere. And so our overall rate is probably higher than that rate. But the other thing that it says, and I know that our panelists will want to talk about this, is that people who have difficulty in traveling, seniors, people with disability, or people that have to work all day and can't get off a job to travel an hour and a half to Rowan or 2 hours to Hackensack University Medical Center in Bergen County, those people can't leave the county to get vaccinated. So we have to do a better job in vaccinating in our own county. And I know this has been a special interest of you, Ashgan, of people who have either special needs or are under great social pressure getting vaccinated. Can you speak to that?
Well, I've been talking to various populations, and I've been seeing some of the challenges that different populations are facing. So some of which you have addressed, especially with homeschooling these days, and young mothers who are not able to just pick up and go and drive far for any reason, much less to go get a vaccine. But I try to also, remind people that we're talking, especially depending on the vaccine, it's only 2 times. So if it's a long drive, it's 2 long drives about a month apart, and then you're done. You're done for hopefully a year or longer. So if we can get some support system in place so that you can make that drive, great. But then I also try to just really provide them with as many resources as possible. And the biggest challenge I'm noticing is the skepticism, not even the access. So some of the vaccine rollout is not as effective as it could be because people are still hesitant to get it. Some people are offered the vaccine. I know personally healthcare workers who have offered the vaccine and still decline, waiting for more data to come in. So these are very, educated people and have access to the data, and they just have a personal hesitation. But especially people of color, and I've spoken to African American and Hispanic communities, and they are hesitant because they sense always something that is rushed and they don't want to be experimented on. And we have, unfortunately, this country has a history of that, and really tragic history of that. So I completely understand their hesitation, and that's why we're doing these things to educate, because education, I believe, will kind of resolve a lot of these problems. So education, organization, we got to get going. And hopefully under the new administration, we've already started, and I think we're up to 1.5 million people getting vaccinated every day. So that's pretty remarkable. I think we're on our way, hopefully, to be done by the end of the summer.
And so thank you. And I just wanted to point out to the membership that Dr. Elshinawy is not at full capacity right now, that she's joining us after an illness. And so I think that she deserves our gratitude, special gratitude for pulling herself off the mat to join us. And so what kind of messages resonate when you talk to people who are skeptical of getting vaccinated? And this is for any of our panelists. So if I were to talk to a friend who said, I'm not going to do that because of Tuskegee or because this was rushed, or should I refer them to a doctor, or what's a message that you think is helpful?
Yeah, I mean,
Richard, what do you?
Richard, go ahead, please.
Yeah, I think, if somebody absolutely is against vaccination, you're sort of up against the wall. But if there's room there to speak to the person, I think you want to elicit why they have their fears of vaccination. You want to sort of break it down and see what is it that why are you hesitant towards the vaccine, and does it relate to things that have happened in the past, or does it relate to things that have happened to you? And I think you'd have to move on to what the vaccine does, where it came from, how it relates to other vaccines and protection in the past, and really bring it down to the understanding of the person you're dealing with.
No, I think Richard answered it perfectly. We have to personalize every answer. There's no like little script that you have to give people. Some people want the data. They want to know the science. Some people want the reassurance. Some people want the example, like I got vaccinated. So I actually tell my story to as many people that want to hear it, and what side effects I had, if any. So I think that goes a long way. So if they have a role model in their life that shows, that had the vaccine, that it goes a long way with some people. So everyone is different, and you have to take that time to see if there's an opening there to help inform them.
So we have an epidemiological question. So why are we told not to get the COVID vaccine for a full 14 days after another vaccination? The questioner said his spouse and he just had a follow-up shingles vaccine and were told not to get the COVID shot for 14 days. Would one shot undermine the other?
Well, I forced myself to sit through all of the both FDA and Advisory Committee on Immunization Practices sessions. And there is a document out there that's very helpful. It's called Interim Clinical Considerations. And maybe we can put this on the website for use of RNA vaccines. The real problem is that they made sure that people who were getting vaccinated like that weren't in the clinical trial. If you follow me. So if you were going to get vaccinated with your shingles vaccine, like my elderly aunt just did, they were glad to have, they were said, this is great. We're happy that you're getting vaccinated, but we don't want you in the trial. So the clearest, the message that came from the Advisory Committee on Immunization Practices was, if you can wait between various vaccinations and the coronavirus vaccine, because we just don't know. They also said, if you can't wait, if there's a reason why, they didn't speculate on what the reason would be, but if there's a reason why you have to get vaccinated with the coronavirus right now, it's not an absolute contraindication. But if you can wait 2 weeks after your, in this case, shingles vaccine, or the other situation has come up too, you get the coronavirus vaccine, but then you want to get the shingles vaccine, we still tell people, wait 2 weeks. Can we prove that they have to wait 2 weeks? No, it is prudent to wait 2 weeks.
That's not a recommendation that's unique to to this vaccine. That's a recommendation that's pretty much takes place with all vaccines. You don't want to concatenate vaccines. In other words, you want to get your vaccine, get your immune response going to that vaccine, and then let that happen. You don't want to then put another stimulant in the middle of that event going on. You want to let the immune response play out, and then you get, if you can, get those, you spread those vaccines out. So you either get all your vaccines at once, generally, but don't get them in between.
Tim, let me jump in here and make one other point that I think it's really important for the audience to hear, and that is, we're in this period right now, and like a lot of these things that have been going on in the coronavirus, each day seems like a week or a month, and each week feels sometimes like a year. We're going to get to sometime pretty soon now. It might be as soon as April 15th. I'm almost certain it's May 15th, and I'm absolutely certain that by June 15th, we're going to have more vaccine than we're going to have vaccinators. We are going to have more, and I can tell you this is true in Princeton. We're going to need more volunteers. I've already recruited the participants. I'm trying to recruit the participants on this call. But there's going to be a flood of vaccination. And if we can make it through this period of, kind of staring into the candy store and seeing the candy in the window, there's going to be a lot of vaccine in probably in April, definitely by June. And we just have to hold out, keep wearing our masks, keep our distance, keep, being paranoid at various places, not spend a lot of time hovering in the soda aisle like I tend to do at the ShopRite. We just have to keep on keeping on. I know I'm giving a speech at this point, but I get very emotional trying to get people to maintain their vigilance, because a type of finish line is in sight. We're not there yet, but it's in sight.
And Tim, if I may add on to the
Please.
question you just asked from the couple, the married couple, for the same reasons that Richard and George have been saying about how not to get 2 vaccines in a row, back to back, wait at least a week or two. Besides the fact that you want to let each vaccine take its role there, the same reasoning is why we tell people who get the actual COVID infection, because I've gotten that question. People have recovered from COVID, and then they ask me, can I get the vaccine now? And I tell them, wait a little bit. So, and there's no strict guideline, but I think the general recommendation now is to wait actually 3 months after you've gotten the COVID infection before you get the COVID vaccine. And part of the reason is because you're already still in a state of inflammation from the infection, and the vaccine may promote more inflammation, and you don't want those two to collide.
There's also a practical reason that's been discussed at the ACIP meetings, and that is, since we can pretty strongly presume that someone who has survived a infection is going to have, as Richard pointed out earlier, at least a 30-day and probably a 90-day protective effect in this period of scarcity. Those people can wait. So it's both, you've been sick, so don't mess with the vaccine. You want to make sure that your immune system is ready to take on the vaccine. But there's a flip side in that you might actually not need it as much as certainly the next healthcare worker or the next 95-year-old or the next person with diabetes. So that's the other reason why there's a relative recommendation to wait.
So there's a question about efficacy, which I think Dr. Elshinawy discussed. So the question is, if the vaccine has a 94% efficacy rate, does that not mean that approximately 1 in 20 are still susceptible to the disease and don't know whether they are part of that percentile? That seems to indicate that continuing to take precautions is wise. The questioner is asking for a comment. And
Well,
Richard, I'll take the vaccine.
I'm not sure if I understand the math, but if it's 94%, it's, so the Pfizer vaccine at 2 weeks post the second dose was 94% efficacious in preventing symptomatic COVID. So that means 5%. 5% of people, were still susceptible. I guess that's 1 in 20, 1 in 20. So yeah, I guess, there's that risk for those people. So it's not, but that's about as high a coverage of vaccine one could expect. The mumps vaccine is a 75% vaccine in the MMR.
Yeah.
So it's pretty good.
And I think the flu vaccine is 60, right, Richard?
On a good year.
On a good year.
Right.
Yeah, I think and this comes up sometimes, Tim, back to your question of how you encourage people to get vaccinated. You're trying to not, it sounds maybe too blunt. You're trying not to die here. The vaccine is a stopper from dying. You still might get sick. That's that 6%. But if I understand it correctly, it stopped almost every death or severe disease in the vaccine populations. Well, there's some of the people got sick. The vaccinated populations had essentially zero or close to zero deaths in the entire study population. That's what we're trying to achieve here. And so maybe you'll get sick if you're one of those 1 in 20, but what we're really trying to do is stop you from dying.
Right, it was 0 of 30 in the Moderna
Exactly.
group.
Yeah,
Okay,
so
not
no
50.
one died, no vaccinated
0,
patients died in the Moderna group. But the efficacy, so someone got sick, but they didn't die.
Usually mild symptoms. So those 5 to 6% got sick, but really, really mild illness.
right? And so, right, anybody would take that, right?
Mhm.
It's like, if, like, think of it as a year ago. Will you take 94% protection and 0 deaths? We all would have taken the bet. I would have taken the bet. In fact, the target for efficacy for all these vaccines was 50%.
Mhm.
That's what the target was in the clinical trials. No
Correct.
one in their right mind imagined these were going to be plus 90 vaccines.
So there's a question about treatment. If people get the virus, is early treatment with monoclonal antibodies available to avoid hospitalization? I understand that other early treatments are effective. Where is it being done and who can get it?
Yes, monoclonal antibodies are available. There's, the ones that have been popularized. There's one produced by Lilly, bamlanivimab, and then there's the Regeneron product, which is a double antibody. Now, they have been shown to reduce progression to disease. Actually, there's a new combination of the Lilly product, bamlanivimab and atezolizumab, and which is really, had a 70% protection and 70% reduction in mortality. Now these monoclonal antibodies have to be given in mild disease. It's not given; they're not given in the hospital. They have to be given essentially before you get sick. It's got to be after the test. You have to have a positive test within the first 10 days, and they can be given at the. They're given it. Well, you're COVID positive now, so you can't go to an office and get it. You have to be at a place where you can be sequestered. So the emergency rooms are giving it. Robert Wood, St. Peter's, I know Central State is giving it. I'm not sure if Princeton's giving it. They probably are.
Mhm.
But that's where you want to, and that's a modality you want to get. Early is definitely better in this setting.
Yeah, and as is true with the other treatment modalities we have, the earlier the better, whether it's the drugs like remdesivir or steroids or even plasma transfusions. Those are the things we are using to fight this infection, and we give those in the hospital, and they have to be given really in the first 5 days of the illness.
So we've heard from some octogenarians who have expressed frustration that the appointments are being overtaken by computer savvy younger people who are not eligible. And a practical question from one of our octogenarians is, while they're waiting to get the vaccine, how risky is it for them to have dental work done?
Well, my first, I'll start with this one. The first answer I always give on these situations is I never give advice to a particular patient on one of these calls. So in general, if your dental work, I recently had to have oral surgery. I had a abscess. I couldn't wait. I had a fever. I needed to be surgerized, to use the colloquial term. So there's nothing I could do about it. And so we don't want people waiting with severe illness, either it be oral illness or some people need to have their blood pressure maintained, their diabetes maintained. People should not be skipping meaningful clinical visits because of this pandemic, because of the problem. You will need to make sure you have adequate protection, and you will need to talk to your clinician. I also have some eye problems. that's an extremely intimate interaction also with my my ophthalmologist. And they have a very specific process to make sure I'm safe and that I go in safely to the facility. So you should, in general, keep your programs. But if it was me, and if it was, let's say, a dental cleaning, I might consider waiting on a dental cleaning as opposed to oral surgery. But I don't know what the other doctors think about that, that framing of the issue.
Yeah, I definitely want to add to that because it goes above dental cleaning, dental work. I agree with everything George just said. If there's an urgency to the procedure, there's really no debate. You got to get it done. And this point in the pandemic, pretty much all the offices, whether it's dentistry or primary care or endoscopies, they are taking everything that they need to do to make sure you are safe and make sure they and their staff are safe there. At the beginning of the pandemic, I couldn't have said that so confidently. The other thing is procedures like endoscopy, colonoscopy, especially people who are high risk or have history of cancer or at high risk for having cancer. I would definitely say, even though it's an elective procedure, please do not delay colonoscopies, because what I've been noticing during the lull that I talked about at the beginning in the summer when we saw less COVID patients and we're kind of taking a breather, we actually saw a lot of other type of patients, and they were coming in with very severe diseases. And I diagnosed a whole lot of cancers that have progressed for months because they've never been detected and because people were kind of skipping out on screening testing. So I'm noticing that trend. And actually, we did a webinar in January out of Rowan, just focusing on that primary care prevention, disease prevention stuff in the setting of a pandemic, to not ignore a very, very important procedures like that.
Thank you. Our next question, is it known from an immunological point of view how COVID-19 evades our immune systems? Is it at the level of T-cell response / differentiation, or some impairment of antibody production / affinity maturation?
Tim, you're teeing this up for our infectious disease specialist here. Richard, what can you say about that?
Well, basically what it does is the viruses mutate, and then they avoid the antibodies that are being produced to inhibit the spike protein and inhibit the ability of the virus to enter the cells. So you're getting evasion on that basis. There's also T-cell responses and other type of cellular responses that actually are important in terms of the immune response, which actually may be helping to protect people despite the fact that we're getting mutations in the virus.
A couple of questions about vaccines. The status of the J&J vaccine, we had heard that it was going to be approved for emergency use a few weeks ago, and I'll
take that one, Tim.
Is there a problem you know of?
No. The way this works is, a few weeks ago, J&J submitted their application. These applications are literally 80,000 pages thick. So what is going to happen this Wednesday? This is actually, believe it or not, quick turnaround time. It's taking the FDA about 2.5 weeks. This Wednesday, there'll be a multi-hour, and it'll be streamed on YouTube and elsewhere, meeting of the FDA's external advisory panel. They will very likely, at the end of asking a lot of questions all day long, they will very likely vote to approve. That then will go to the FDA acting administrator, and almost certainly that evening, Wednesday evening, the FDA, either that or the next morning, the FDA will approve the J&J vaccine under an emergency use authorization. Then the Centers for Disease Control Advisory Committee on Immunization Practices will meet potentially as early as Thursday. I suspect it might be Friday, just so those physicians and epidemiologists can read the paperwork that they will be given by the FDA. So they'll probably meet on Friday and Saturday. And so I'm expecting the final authorization on Sunday, and the J&J will probably be ready to ship this coming Monday, because that's the way it worked with Pfizer, and that's the way it worked with BioNTech, Moderna BioNTech. Once they got that ACIP recommendation that goes to the CDC director signs off on that, and literally the packages are ready to be put on the airplane, waiting for that CDC signature.
Either of the other doctors like to weigh in on the question?
I've been hearing the same thing, that in the next couple of weeks, we're waiting for the Johnson & Johnson, and that we're going to have quite a bit of vaccines available. And like I think George predicted, we're going to have more needles than people to administer the needles, which is a good problem to have.
That's right.
As long as it's a short-term problem.
That's the problem we want.
Mm-hmm.
And it's a one-shot vaccine, so it should be easy to give, and we should be able to vaccinate a lot of people with reasonable efficacy.
So there's a question that I think I'd like you all to address, and that's since the efficacy is so high for these mRNA vaccines, what do you think the future is for other vaccines using the mRNA methodology?
I think now that the blueprint is there and the technology is there and they've shown it to work, I'm personally excited to see it, maybe be used for the common cold, for the influenza virus, because like we said, the flu shot is kind of a coin toss if it's going to work one season to the next, and it would be lovely to have this messenger RNA technology to be used for it, because I don't want to underestimate the flu, because it really kills a whole lot of people every year too. It's just we don't talk about it because it's not a real pandemic, and it hasn't been a pandemic for a long time. So I can see it being used for even things outside of infections like cancers. So it's a very exciting time, and money talks. As long as there's money, we should be able to accomplish this.
Yeah, there's, as Ashgan's saying, there are trials that are looking at mRNA technology for cancer. I didn't state earlier that this mRNA, it's a little piece of it's just a bunch of amino acids that that go into the cytoplasm of the cell. They're picked up by the ribosome, and then the spike protein is then generated. It's just made. Does not enter the nucleus of the cell. It's not part of the genetic machinery. It's just in the cytoplasm with 200,000 other pieces of mRNA. It shoots these proteins out, which are, and then you make antibodies to it, and then it disappears in about a week or two. So it's a very interesting technology, and they can adapt it for probably, hopefully, many different diseases.
Before we go to your closing statements, do you think that COVID-19 will be with us for many years ahead, and will annual vaccinations of the sort that we may or may not get for the flu become our reality going forward?
I have a suspicion that we're going to be dealing with it, maybe not necessarily indefinitely, and I'll explain why, but I think most likely for at least 2 or 3 years, just from what we're seeing. And I think part of it, not to put blame on any group, people, or one person or anything, but we let this pandemic run wild for a little too long. And unfortunately, the viruses, they love to mutate, and they mutate an average once a month. And we've had this pandemic now for 12 months. So we have about 7 US strains, right? New COVID strains, in addition to the UK, South Africa, Brazil strains that have entered our country. So I think we're going to have to deal with that, and we're going to have to work on booster shots and modifying the vaccines for the future. So I think we can possibly achieve herd immunity, but it doesn't mean the virus has left us. It just means it has less people to infect, which means that it'll probably be around seasonally, I would think. I'm not an infectious disease or a virologist, but specialist, but I would think since it's been going on for so long, I think it's going to be around for at least another 2 or 3 years. But I'm hoping not like the flu, because we have new technology to combat it that we don't have for the flu.
Yeah, I agree with that. I think we're gonna be having to deal with these different variants. Hopefully they'll be able to have something akin to multivalent vaccines like we do with the flu. And I think it's gonna be around.
The thing from an epidemiologic point of view that I know some of my colleagues have started to highlight is that if you take the, if you will, 20-year view, about 15 years ago, we saw the first SARS vaccine. If you remember a year ago, this was like the new SARS. And then we also saw, so this is actually SARS-CoV-2. And then we saw MERS, the Middle Eastern respiratory syndrome. So if you look at the past 15 years, several people in epidemiology and public health have already written in very loud manner in the Wall Street Journal and New York Times, other places, that if it ain't this one that we keep seeing, it'll be another one, just because we've seen 3 in fewer than 20 years. So I think I share the optimism of the other panelists on this particular coronavirus, but we need an infrastructure that is an early warning system. So as described, we're not playing catch-up baseball. And then maybe with this methodology, the mRNA methodology, but also the J&J is using an adenovirus methodology that they used actually to develop, I believe, and Richard, you can tell me if I've got this one right. I think they use this for the Ebola virus. So this is not the mRNA vehicle is not the only modern vehicle. So we're fortunate if we set up an early warning system of viral detection, we will have techniques to create viruses quickly, but we're going to have to do this prevention activity of setting up sentinel, being able to identify these new viruses before they get out of hand, as was described.
Well, thank you, all 3 of you, very much for your generosity of time. And we're going to ask you to share any closing thoughts you would like to, but on behalf of the programming committee, thank you. We've gotten a lot of positive comments in the chat, and we really appreciate you coming along. So while you think about what you want to say, I'm going to move Ashgan over, and I'm going to try to disappear myself. This is our first time doing this, so thank you for your patience. Ashgan, you need to start your video for me to spotlight you. All right, great. Now add spotlight. Good. And now I'm going to try to get out of here.
Thank you, Tim.
I can't figure that out, so I'll just turn off my camera. There you go. So I think we're at final thoughts from the panelists.
Well, I just want to thank everybody for participating, and thank I have the greatest respect for doctors like Richard and Ashgan who are on the front lines. And so thank you very much for, at the end of your very, very long days, sharing your understanding and experiences with us.
Thank you, George. I want to say thank you for inviting me to be on this panel. And again, as Tim mentioned, I'm a little under the weather since last night, so I apologize if I'm at subpar level here, but did my best. I want to just kind of round up this conversation from my point of view by saying how incredibly important it is to educate and support each other throughout this process. And, you know, regardless of how many people are on this session, whether it's 50, 60 people, I hope you take whatever you learned from this and share it with your loved ones, your family, friends, neighbors, because a lot of people have questions. And I really love the question that came out that said, you know, how about us who, you know, don't have the computer resources or not as savvy and stuff. So those are some of the people that can't even join in a Zoom webinar like this and can't access this information. So if you have access to people like that who would like to know, would like to learn, please do share what you can with them. Because remember, this is not just about a me this is going to be about me and everyone else, because if I get the vaccine, I'm helping the people that live in my home and hopefully the people in my workplace, in the hospital, in the office, in my family, and you have to look at it the same way. So don't get upset if someone got a vaccine before you, and you try to compare their age groups and their chronic illnesses and whatnot. Remember, the one more person gets a vaccine, it's really helping the whole of us. So we have to encourage each other to learn about it and to get the vaccines, because remember, we want to achieve that herd immunity. So, and I would encourage you to talk to your doctors if you have a specific chronic illness or a chronic, you know, concern that you have for the vaccine. Please speak to your doctor about your specific history and experience with this vaccine. So, and we are resources. I'm happy to provide my information if anybody wants to ask questions afterwards. Because at the end of the day, we're here to educate and help you make informed decisions. So I wish you all well. Thank you.
Yeah, I just want to say that it's a real honor to be on this panel and be invited to this panel. It's really been a great evening. The questions have been interesting and food for thought. And I think it's just to reiterate what's been said, we just have to maintain our vigilance with this disease. We have to use all modalities that we have available to us to drive this virus down. And it's the protection, the mechanical protection that we have available, as well as the vaccinations and you know, the knowledge that we have to keep this virus from spreading between us.
Thank you. Thank you, Dr. Snepar, Dr. DiFerdinando, and Dr. Elshinawy for this very informative panel discussion. This was such an important conversation for our community, and many thanks also to Pcdo's programming chair, Tim Quinn, for all his work to coordinate this important program. We will be emailing you Dr. Elshinawy's slides and other resources related to vaccines later tonight. A special thanks to Dr. Elshinawy for joining us tonight despite not feeling 100%. You are a star. And thanks once again to all our amazing panelists for a very informative program. Now, I'd like to invite Princeton's Mayor Mark Frieda to give us an update on vaccines locally. Mark, if you would please join us.
Thank you. Hi, everybody. I'm sorry I actually was late to the call, but pretty much from 6 p.m. to 8 p.m. tonight, I was on phone calls with county and state officials and all the mayors in Mercer County talking about the vaccine rollout in Mercer County. And between Friday morning and this evening, there's been at least 4 calls that myself or the health officer have attended, trying to coordinate with the county and the state how to improve what's going on with the vaccine rollout. In Mercer County so far, 32,842 people have received a first dose shot, and 12,694 people have gotten the second dose shot. The doses per week coming into the county right now are 2,000 per week. We were hoping for next week that would go up to 2,600. But as you all know, watching the news, there's a bunch of delivery problems with weather in Texas and other places on the East Coast right now. So we might not get that increased number of doses until the following week. There's 2 sites in the county that the state and the county are trying to have us focus on sending people to: the Cure Arena and Mercer County Community College. The mayors are united, strongly united, in pushing back on the county and the state that having only those 2 sites and no longer having the local clinics in many of the municipalities is not serving our populations to the degree they should be served. So there's an ongoing aggressive debate over this. I will tell you that Princeton is one of the towns leading the charge against the county and state as far as thinking that not having local clinics is somehow a good idea right now. So obviously there's got to be some balance. We don't have enough doses of vaccine, but we're pushing the county and state to agree that at some level of doses per week, those local clinics come back. There are people that just cannot go to those 2 sites. They don't have transportation. They don't have internet. They have no way of knowing when it's their turn. You're not going to send a 90-some-year-old person to stand outside in the cold at the Cure Arena for an hour waiting to get their shot. Just doesn't make sense. So anyway, we're working hard. We're trying hard. We ask people to be patient. The state is working diligently to make the state registration, the VSS system, work much better than it does now. It's an ongoing process, but they are putting a lot of effort into that. So anyway, I know it's been a long session. I don't want to tie things up, but in a nutshell, that's what's happening right now.
Thanks so much, Mark. We really appreciate the update and all you're doing to ensure our safety and our well-being. Thank you once again to all our panelists. And as Dr. Elshinawy said, please go ahead and share this information and everything you learned tonight, share it widely with everyone you know and on all the different forums. You know, we will be sharing a recording of this session on our website, so please look for that. And we encourage you to share that wherever possible. Now, just a reminder once more, the PCDO statewide, county, and local endorsement candidate forum is on Sunday, March 14th at 6 p.m. and it will take place virtually. The link will be provided on the PCDO website. And once again, as per our bylaws, in order to vote at the meeting, you must become a member by February 28th, which is 14 days prior to the endorsement meeting. As mentioned, the PCDO has eliminated our membership dues last year. And in order to become a member, you have to go to our website and click on the Join Renew tab. More information will follow in our newsletter on Tuesday, and I'll be sending a special announcement with more information this week. Thank you everyone for joining us for this important discussion tonight, and we look forward to seeing you on March 14th at 6 p.m. Good night.